Good afternoon, everybody. See this temporomandibular joint, I'm just going to explain it, where to keep a probe, how to do it. Then I'll show you the normal anatomy of that, and there are two pathological cases so that you can visualize first where I'm going to, because that video camera has started working now. So you'll see that where I'm going to keep and how to do this one on both sides. First you observe it. After that I'll show it in this monitor, this side monitor, that left hand side, right hand side monitor, the normal anatomy of the temporomandibular joint, disc space, mandibular condyle and fossa. Okay, that I'm going to explain it to you. Simple. Patient should be in a sitting posture. For whenever I do this temporomandibular joint, patient should be in a sitting posture, and then you just, I am turning the one side, that is the right side. Right side. I'll keep my thumb on the tragus of the ear. Okay, when I keep my thumb on the tragus of the ear, I can feel the condyle or fossa. Okay, when I feel that condyle or fossa, I will palpate it in a deeper palpation, so that bony part I can able to feel. Even you can do it on your own and then feel that one. So definitely it is a simple thing. Okay, can you feel that one? So that is the mandibular condyle. Okay, then see, then I will ask him to open the mouth and close it. That is, see, you see my thumb, I am keeping it on the tragus of the ear, and then I am asking him to open the mouth and close it slowly, so that you can feel the movement of that, and the movement of that joint, temporomandibular joint, you can feel it. You can also keep your hand on the temporomandibular joint. Please do that one. Can you feel that one? See, it is moving. That is the temporomandibular joint. Okay, that is the palpation, right? Similarly, what you do, this is the single one, I have kept it. I am keeping it on the both sides. I am keeping it here. I am asking him to open and close it. Close, open. See, this is to identify the symmetry of the temporomandibular. Sometimes unilaterally the temporomandibular joint will dislocate or dysarthrosis will be there. Feeling will not be there. So for that reason, the clinical examination is very, very important when you are doing for this temporomandibular joint. Slowly, then first thing you do this one. Next, fast then you can definitely feel the contour abnormalities by palpation. Okay, after doing this, right, that I am again keeping my thumb on the tragus of the ear. I am pulling the tragus because it is very close to the tragus of the ear. So I am just push that tragus of the ear to the more towards the ear. Okay, and then I will apply lot of gel. That is the most important one. You have to apply lot of gel there, and keep a transducer like this. Longitudinally you keep it, and more of your transducer come over the tragus of the ear. That is what you have to do it. When you keep it there, you can see the joint space, what I have shown it in the morning class. Please somebody operate this machine. Now look at this side. In between what you are seeing here, cursor is not coming. Cursor is not seeing it here. Cursor not seeing. Pointer. Okay. See, this is the bone, and this one is the condyle, and this is the articular disc. So normal, homogeneous, that discoid shape. See, that is the temporomandibular joint. Forward movement is there, and then in open mouth and closed mouth you will assess the articular disc, joint spaces and all. This smoothness should be there. Freeze. Roll back. See, that white line is there, no? That smoothness has to come. Yeah, that is the smoothness. if there is any irregularity in that, that condyle is irregular and osteoarthrosis or ankylosis is suspected, and the black area, that hypoechoic area what you are seeing is the articular disc. Okay, these two things only, open mouth and closed mouth, and the dynamic action la you assess the temporomandibular joint. Similarly, you go to the, sometime you put a split screen, you put a split screen, see for the opposite side, pull the tragus to the one side and then keep it. You have to see this, that white one, that is the mandible. Yes, so you can see the movement. You can see it is coming back to the mandibular fossa. You can see that one. So when that is smooth movement is there, sometimes you might have experienced or you might have seen that click sound, right? Articular disc has been eroded, click sound will be there. So that is a clinical indication for doing this temporomandibular joint. I'm going to demonstrate the pathological one, 2 cases. That time I will show you the how this is what you have to see, smoothness of the condyle and the articular disc which has to be hypoechoic. That's all. These 2 things you have to follow it up. Thanks. See, his complaint is he is not able to open the mouth completely. See, only this much only he can do it. See, only this much only. There is a restriction of opening of the mouth. That is why only he has come for that. So when I feel also, when we are feeling it, see, sometimes you have to feel yourself, that you consider yours is a normal one. So that feel, I can feel that one, it is not, the contour is not smooth at all. So I am expecting a bony pathology in this case. Okay, so that is what what I am expecting it, right? See, see, the contour is not smooth at all. Cursor, you just show me. No, pointer. That one, you see that it is not smooth at all. That is irregularity. Can you see that the irregularity is there? See, restriction is there. See, not like that previous one, normal steady. It was going out of the mandibular fossa and then coming out. But here it is not going at all. There is definitely that restriction is there, and also irregularity is there. This is typical of a bony ankylosis. Okay. Split screen. You see that irregularity of the contour of the yes, that's a bone, mandibular, and the disc space also is very much reduced. This is bony ankylosis causing this temporomandibular joint bony ankylosis. See, sometimes what will happen, because of gel, what will happen, it will slip from there when he is doing it. This is see, it is not opening at all, it is not slipping out of that fossa at all. So that is typical of a bony ankylosis. Okay, understood? Right, fine. Thanks. You see, patient has got earache. Okay, earache, and then the previous patient I have shown it, he is not able to open the mouth completely. Okay, only 50% only is able to open. But here you see this. See, he is able to open that mouth, right? Almost 80-90% he is able to open that mouth. But when I am palpating, that is only that a very important one is you have to do the clinical examination before doing this. See, you see, I am just keeping my thumb on this area. I can feel the click, or that fossa itself is, see my hand is going like this. See, this one is going like this. That means what has happened? Clinical examination, what do you call this? Subluxation. Yes, subluxation or a dislocation. Right, that we will see it in the ultrasound, because difficult to differentiate these two, subluxation and a dislocation. See, I am keeping my finger in a closed mouth, right? You are seeing that one. See, I can insinuate my finger. So that is definitely, this is going to be a dislocation or a subluxation. And then this is one side I have done it. I am keeping both my fingers here. Yes, I see this side also it is, I can insert it. So definitely it is going to be a subluxation or dislocation. To confirm that one, what I will do the same, the temporomandibular joint. I am pushing the tragus towards the ear and then feel that area. See, you can see that fossa, deep fossa. That black one is the deep fossa. See, because of that, it is slipping out of that. That contact is going off. That is the bone. See, I can feel the click also with my probe. See, I can feel my click there, and it is subluxation. See, the contact is maintained, but it is not going out. So that's why I am calling it as a subluxation. See, that is typical of the subluxation of the temporomandibular joint. Articular surface also, that articular disc also has become narrowed. You see that discoid shape, that black one. You just show it. That one. That is the discoid shaped one. That has also reduced here. Okay. See, it is going back there. See, it is coming out. Yes. So that way, this dynamic actions, like you can demonstrate this subluxation or dislocation of the temporomandibular joint. Still, subtle changes of the articular disc, if you want to study it, better you go for a MRI. MRI will be the best. This is a screening modality only. Even this one, you can, if you take pan tomography, you can see the bone abnormality. But open mouth closed view, how much the dislocation or a subluxation, that you can identify it. When you do a dynamic action, you can find out. But still, when you are going to operate this case, you want a roadmap for that, then better to do a MRI scan. Any doubts in this? Clinically, anybody wants to palpate this one, this ideal case for subluxation or dislocation of the temporomandibular joint. சரி.
இல்ல பக்கத்துல வலிக்குது வீங்கிருச்சு இன்னைக்கு தான் வத்திருக்கு காதுல இருந்து
வலிக்குது. ஓகே, கொஞ்சம் படுத்துங்களோ. Certain examination you have to do it in a sitting posture, certain examination you have to do it in a lying posture only, right? Temporomandibular joint sitting posture only, you cannot do it, you don't do it, try to do it with a lying posture. Lymph node examination, what he was doing is under the periapical abscess, like that suspected, you do it in a patient also will feel comfortable in a lying posture. கொஞ்சம் படுத்துங்க, இப்படி என்ன பார்த்த மாதிரி படுத்துங்க, இங்கே காட்டுங்க, பார்த்து மெல்ல மெல்ல இப்படி இப்படி என்ன பார்த்த மாதிரி படுத்துங்க, என்ன பார்த்த மாதிரி படுத்துங்க. See, she was telling 3 days before she was having a swelling here. Now it has subsided, but clinically I can see. See, this area there is a swelling is still there. Still there. 10% of the swelling is still seen here. Okay. What I will do is, before you do this abnormal pathology, always do it on the normal side first. So you'll have a clinical orientation. If you want, you can do a split screen, both sides. One side will be normal, other side will be abnormal. So beginning, when you are started doing it, you will appreciate the normal anatomy one side and the abnormal anatomy. So whether pathology is there or not, that you can appreciate it better. அந்த பக்கம் திரும்ப நம்ம படம், இந்த பக்கம் ஒன்றும் இல்லை, இந்த பக்கம் ஒன்றும் இல்லைல்ல, ரைட். Now I am going to just do this first, that apical lesion, periapical lesion on the right side of the patient. Okay, that is without any lesion is there. What beautifully explained, skin subcutaneous plane, skin subcutaneous plane, and the muscle, that is the muscle, down is the muscle, that muscle, and the bone. Okay, beyond the bone, because all sound will get absorbed by the bone, beyond that nothing will be seen. So that is typical of the normal one, that is the mandible bone. Okay, dual. Okay, see, after seeing this one, no, first you have to see it in the vertical position, madam. Longitudinally you drew, take it this side. Longitudinal, I am just keeping it longitudinal. Okay, when I do a cross section, this is the cross section, but first you have to do it along the line of the mandible and look for the any pathology in that. If you offer it this one, zoom it, depth increase. Yes, okay, that's fine. Stop. Okay, I'm just palpating the lesion here. You see the difference? That's a periapical lesion. Okay, you see the difference. That is only I am telling you to observe it in a dual position, that is in the split screen one. You can appreciate that periapical abscess there, hypoechoic area, right? And that is the lesion. Yeah, that is the lesion. Vascularity. Reduce. You see this vascularity, there is a increased vascularity is there. Power Doppler. Yeah. You see, that is the vessel which is supplying that one, and there is a increased vascularity is there. So it is typical of a inflammatory lesion, not a tumor like thing. It's a inflammatory lesion. Okay, right. Now I'm just going to see for the lymph node. Beautifully Dr. Rajiv has shown you the stations. What I'm going to show you, in the camera on, like inge kattu. See, this is the submental, okay, submental, and this is the submandibular, okay, okay. This is the submental and this is the submandibular, upper deep cervical. This is upper deep cervical and mid cervical area. This is mid cervical this sternocleidomastoid muscle, and this is the mid cervical area, and lower cervical area. This is the lower cervical area, and then when I come here, this is the supraclavicular and posterior triangle. So this way, when I look for the cervical lymph node, see, I'll start from the symphysis mentae and then come in this fashion, come here, and then go like this, and then go here, and then supraclavicular, then posterior triangle, so that I will not miss any of the lymph nodes like that. Like a Z, it is like this, and then come here, down, and then go up to the posterior triangle. When I look it like that, I will not. So identification, wherever it is there, you just make a note of it. That's all. That will show you that where the lymph node is there. என்ன பார்த்த மாதிரி பாருங்க. அப்படியே இந்த சைடு தான் வலிக்குதா? ஓகே, கொஞ்சம் இந்த பக்கம் நீங்க நேரா பாருங்க. என்ன பாருங்க, நீங்க என்ன பாருங்க, நான் பார்த்தேன். She is having a pain on the left side, so I am going to see for the left side lymph node. கொஞ்சம் தள்ளி வாங்க. இந்த மிஷின் you can push. Just stop it. See, now I am keeping it just below the symphysis mentae. Okay, that what muscle you are seeing it there. These two are the muscles on either side. If anything is there, just point to. That is the muscle. This is the submental lymph node. This one. Yeah. That is one. And then I am going below the angle of the mandible, right? Here only. That is the submandibular lymph node. Yes, that is the submandibular lymph node. Okay. Then the fatty hilum is there. Then I'll just go up to the upper deep cervical. See, that is the upper deep cervical lymph node. Here, that one is there. Hilum is in the central, so it most likely to be benign lesion. Okay. Then I'll change my probe direction. See, this carotid artery will be the landmark for us. You see the intima and then pulsating one. Yes. So just above, I am just taking it. I am seeing the upper deep cervical lymph node, that is one, and then this middle small lymph node. It is not very significant one. That one above is that is the lymph node. Then I am coming down, right? See, lower cervical, one more lymph node is there. Okay, and then supraclavicular I am going. That is the white line is the clavicle bone. Just above that, if there is any lymph node is there, that you can see it. And then posterior to the sternocleidomastoid, this is the sternocleidomastoid muscle. What you are seeing is the sternocleidomastoid muscle. Posteriorly, I am keeping that one. If there is any lymph node is there, that you can see it here in the posterior triangle. So when you do that one, and then this is in a longitudinal section I was doing it, I will do again a cross section on that places, and that also will brought out the lymph nodes in a cross section. See, this is the carotid artery. and the above upper deep cervical one lymph node is there. Then I'm just coming down mid cervical and then lower cervical and then supraclavicular, then posterior triangle. So in that order when you go, you will not miss any of the cervical lymph node. Similarly, I will do it on the right hand side, then come down, that is the below the angle of the mandible. You will see that submandibular gland and all here, and then you see that there is one, that is the jugular vein. That is the jugular vein which is compressible one, and then you will see this, that is the thyroid gland. Yes. And then supraclavicular and the posterior triangle. This posterior triangle, any nodes are there that you can see it. You have to do in cross section as well as in a longitudinal section to look for the lymph nodes. Okay, that is about the cervical lymph node. So this patient has got a periapical abscess or periapical lesion and the cervical lymph node on the left side. Thanks.
RBC alone you are mentioning. What about other cells? Why can't other cells to be
Anything that is moving can be seen.
moving? I see.
Whichever it
only
is
RBC.
moving is can be seen.
That's what. When the second presentation, like, even it was able to show that serous fluid under the graft.
But that will not show color because they are not moving around. They have to move at a specific velocity. Basically, what happens in color Doppler is we'll be able to set scales. The computer cannot identify velocities from using a wide range. So what happens is it is like a slider. See the range of velocities that a computer or the ultrasound machine can detect will be limited. Say around plus 20 to minus 20, something similar to that. Okay. So this scale can be moved up or down. So basically, you can't say to the computer detect velocities from 0 to say like 300, 400 centimeters per second. It can't do that. Okay. So every time you'll have to set a velocity scale. So within that scale, whatever vessels, the velocity of the vessels fall, those will be detected. Other velocities will not be detected, which is why we'll have to adjust the PRF every time you image vessels that might have vastly differing velocities. For example, I am going to see an artery and I am expecting flow of around 400 centimeters per second. Then I will increase the PRF. Next, immediately I am going to see a vein and I am expecting flow of say like 10 or 20 centimeters per second. Again, I have to adjust the settings. I will have to reduce the PRF and make the computer sensitive to that lower velocities. And for Madam's question, only RBC moves at a decent velocity for ultrasound to be picked up. Sometimes we do pick up signals of movement other than RBC as well, especially so in case of AV malformations or AV fistulae, where the what you call like a bruit, right? A bruit is some sort of a thrill or a vibration the tissues surrounding the AV malformation or AV fistula have. So that is basically the tissue surrounding the AV disconnect, abnormal connection vibrating. So that can be picked up as a mosaic of color on color Doppler, which we will call as a visible bruit. That is, we call it visible bruit. So very few cases outside the RBC realm where we actually identify movement of this particular velocity scale to be picked up on color Doppler. So if we have very slow flow circulation of fluid, it's very difficult to pick up. So lymphatics is a little difficult. Beg your pardon. Lymphatics, the diagnostic hallmarkers, they will not show flow. They will not show flow. And even slower than lymphatics, or maybe at the same level as your Brownian movement of particles that I talked about, an abscess or an hematoma that's extruded serum. And all that you'll have very low level echoes, which when you move the patient about will show movement on grayscale, but when you put color you will not see it, because that is not in the velocity. Yeah, the one other might not be relevant to you, but ureteric jets. your urine gushing into the bladder. That's also at a relevant, it's a decent velocity for us to see it on color Doppler. And might not be relevant to the head and neck region. We can't see the salivary flow in the salivary duct. The next time I think somebody is going to ask it. We can't see all that.
You talked about seroma.
Right, that's right, sir.
So where sutures are placed, below that irritation produces sometimes serum exudates.
That's right, sir.
So every time serum exudate comes, you call it seroma is just a term you use just for expression, or
No, sir. Basically, a non-infected fluid collection, we would call it a seroma. How we say whether it's infected or non-infected is we'll put color. So any surrounding hyperemia would indicate an infection. So in such a case, increase of surrounding color with internal echoes, I'll probably be resigned to call it an abscess. But no surrounding hyperemia, relatively clean anechoic collection, I would call it a seroma. But if it is a clean anechoic collection with no hyperemia, but not anechoic, but lot of internal echoes, then it could be a post-op hematoma, because hematomas again are not very hyperemic surrounding. So depending upon our imaging and Doppler findings, we will be able to try and arrive at a diagnosis. Doppler is also very good for seeing the vascularity of flaps, not just collections underneath the flaps, but as such the vascularity. Sometimes we have flap rejections and all. Similar to what I told happened, very low resistance bed of the flap naturally becomes slowly a high resistance bed. It eventually won't find any vascularity at all. So that happens in flap rejection and avascular necrosis of the flap, which happens in most of the conditions when you do in head and neck malignancies after reconstructive purposes we keep a flap. The pedicle flap, I think the flap will go in for rejection.
Abscesses and the granuloma, how are they coming up on the ultrasound? Because they lie within the body of the mandible.
Exactly.
And since bone, as you said, the
Yes. So what happens is the bone that is there in the periapical, region is not a very hard cortical bone like that of the mandible. I told you even mandibular lesions can be seen provided they become big enough to expand the cortex. So in periapical lesions, because of their superficial location, they do expand and thin out the cortex to a certain extent where ultrasound is able to pass through. So we are able to image if they are located deeper and if it is a well corticated bone, then it is difficult. Even mandibular lesions, if they are deep seated and they are not expanding or thinning out the cortex, then we will not be able to visualize. Only when the cortex is thick cortex is expanded and thinned out to a certain degree will it be amenable to the transmission of sound. In fact, to your question, they say that dentine is the most what do you call the hardest structure, and enamel, right? So not dentine. I'm sorry. I'm very bad with dentistry. You should teach me dentistry. Okay. So recent papers have come where you can actually put a very low frequency probe on the tooth and image the pulp space. So a lot of 2 or 3 papers have come where we actually tried that, and with a very low frequency probe, not this probe, I showed you the curvilinear probe there, right? It has a very low frequency. So using a lower frequency, you're able to get a slightly better penetration, and you're able to barely visualize the pulse space. If you have to still do more work on that, we need much more lower frequency probes, maybe special probes with a special frequency so that you can image that. That's the question as to how ultrasound can actually penetrate in certain areas. That's right. Lot of modes are there. There's the B mode is the brightness mode or the regular this thing. I did not talk to you in detail about power Doppler. Power Doppler is there, so that's a completely different this thing altogether. Then contrast ultrasound is there, where you inject contrast and you see whether the lesions are taking up contrast. So, and a lot of new things are there actually. So M mode, basically we don't have any application. We have something called an A mode that is used in your eyes, so for ocular applications. But M mode as such, it is not. M mode is more like movement mode. So that is not. That is primarily for visualizing the heart and the chambers of the heart and the fetus and all that. In head and neck applications, a few other things that might be of relevance to you, which we have not taken today because it's a little bit of a primer, is your power Doppler and your contrast enhanced ultrasound. So both of them hold a lot of promise in head and neck lesions. Which I'll maybe talk about the next CME if Madam is kind enough to arrange one more. Thank you.
Finally, we came to the end of our long day Cde program. Now it's time for tea break, and regarding the certificates are not ready. Please kindly excuse us for the inconvenient cost, and the certificates will be handed over to the particular colleges in a day or two. And
I just request everyone to stay for a photograph, and after that we can go have our tea. Thank you.
For joining this program and making a grand success. We are delighted to serve you, and we are very pleasure meeting all of you, especially my guest speakers. Special thanks for all the guest speakers, team of guest speakers. Really, I'm so delighted with your all presentations and interpretations. We really learned a lot. If we continue just like this within 1 week, we could able to achieve almost equal to you people. Thank you very much. Thank you one and all.
We are extremely grateful for Dr. Saraswati Gopal and the entire team of Meenakshi Ammal Dental College for having organized this wonderful Cde program for all of us. Lot of things we could learn, and of course a special thanks to the entire team of ultrasonologists who have come and tried to make us learn at least something. We can't learn. Madam says within 1 week we can match them. Not 1 week, even 1 year is not enough to match you. We don't have any intentions of matching you. Only learning from you, trying to utilize it as far as we are, it's possible. Thank you so much, madam.